report was developed by the Health and Human Services Subcommittee of the association, and it really was a report developed by the local government officials, whether it was county managers or county commissioners, and its goal was to look at what they could do as local governments to better engage with and understand the role of LME MCOs across the state. So this is your report. This is a report of the association. And it's very easy to read. They came up with, I think, 6 recommendations that were fairly broad. And since that time, the association and the Health and Human Services Subcommittee has pulled together. They had a meeting. Brian Shuping and I were able to attend. It was called the World Cafe. And basically what they did was they took this report and looked at each specific recommendation in hopes of developing a toolkit. And at that meeting, which was represented by county managers, county commissioners, there were folks from the state, from the Division of Mental Health, from LME MCOs across the state. We all worked as a group, breaking down in different tables, and sort of did a round robin and looked at a variety of strategies. So I wanted you all to see, and that's the second part, is the results and sort of the strategies and toolkits that this group came up with. Many of these were just part of a brainstorming session, and wanted you to have it and maybe talk about your desire as our County Commissioner Advisory Board of how you would like to look at this. I would like to ask Paige to maybe talk a bit about it. She was a member of the group that worked on the not the recommendations, but the information on the strategies and the toolkit. Maybe you could just speak to what we sort of did that day, or your thoughts about what you all would like to do with this report.
I am a member of the HHS committee for the CACC, and it's been a great opportunity for me. The World Cafe, what was really terrific about it was probably the first time in my limited career as a county commissioner, I'm the first termer, to have an opportunity to spend time with all of the LME MCOs from across the state. All of the entities were represented there. So we had tables that took each table had a different strategy, and all of the groups went through all of the strategies. So the compilation, and Patrice Ressler, who's the assistant director of the NCACC, was there facilitating the day and helped us by compiling all of the information that was reported out. But what we were challenged with is trying to take the NCACC recommendations on developing a better relationship with your LME and how that would actually look when we're on the ground trying to have this relationship with the LME. So what you'll see in this report are some very good strategies, how this could be accomplished, how you can increase communication in your community, how you can increase the working relationships with the different county departments that are impacted. It was just a really, really helpful opportunity to hear what other LME MCOs are doing, how they've built those relationships, and what the opportunities are. So I'm very excited about this, and Elaine and I were talking about it in the car on the way over tonight. You know, the opportunity here, particularly for your public health departments to be on your front line, is very important. But it's also very important that we get our public health directors engaged in that conversation ASAP, so that we can figure out what's going to work in our counties and how we can make that happen very quickly. So it's very exciting to me. You know, I've been very pleased being on this board in the time that I've been, and the opportunities that we've had to see increasing services, get our questions answered. So I look upon this as a win-win for all of us.
Brian Shuping is the Senior Director for Community Collaboration, and while I work with you directly, Brian and his staff are many of the community collaboration staff you got to meet at our county meetings, and they're the folks, sort of the boots on the ground who are out there every day. So he attended the meeting and was involved in the strategies. But did you want to add anything about the meeting, and then we can sort of?
Yeah, I just wanted to mention a couple things about the 6 recommendations. That's on page 2. Just a couple notes here. So recommendation number 3 is to have system of care collaborative child services in each county. We currently have 13 that cover 14 counties. Those are ones that are specific child collaboratives, but we have talked about those issues in all the counties in some variety of collaborative, but those are child-specific focus, so we have 13 of those. Recommendation 14, talking about access to services, public health. We've got a project in Community Reinvest 2016 that is proposing to put kiosks in the health departments to do some screenings in the lobby and help bridge that gap. So that's something that's coming. And also just wanted to mention with number 5 around crisis intervention trainings is this calendar year we're on target to offer 20 of those, which is more than doubled our efforts last year. So just wanted to point out those.
Anybody have any questions? Okay. So what we'd like you to do is look at this report from Smoky's perspective. If you, as either an individual county or as the group, would like to sort of look at this and define what you would like to do in relation to your county and how Smoky is doing things to document that, we're certainly willing to help in that way. I wanted to just offer a quick report on the status of the next round of county engagement. We did finish our first round of the county meetings where we invited you as our County Commissioner Advisory Board members as well as community stakeholders together to talk about what was working well, opportunities for improvement, to tell you about what was happening in the community as far as what Smoky was doing, and to provide you with some dashboard reporting that you had been requesting. That round has done. We've been finishing up a lot of the tasks that have been done. One of the outcomes of the county meeting is actually happening tonight in Jackson County. The library is hosting a forum. There are multiple other kinds of things that have been completed. I am in the process, I'm almost finished with scheduling to come out and make a presentation to your Board of Commissioners. I started this several weeks ago. Most of you meet on the first and third Monday, so it's going to take me through the summer. So I'm trying to finalize that schedule. In between the meetings with the full presentation, I'll be coming out if you'd like, and I'm going to try to drum up some business so I can maybe meet with you as a county manager, and if you'd like with the Commissioner Advisory Board member, just to sort of touch base and make sure we don't lose any time together if there are issues you'd like to have addressed. And then in the fall, we'll be hopefully scheduling our second of our twice yearly county meetings as we had talked about doing. So. Go ahead.
I'm sorry, Vicki. Last night at our meeting, we received your quarterly monitoring report.
The fiscal monitoring
Fiscal monitoring report,
yes.
we received that. And we have one commissioner in particular that continues to ask, sort of basically show him the money. And so I guess I would be interested in knowing if there is some way when we get that quarterly fiscal monitoring report, and I don't know, I mean, we don't formally vote on it, so I'm really not sure why we're even bringing it up at our meetings. But the point being, I tried to tell him that, we're only giving you $99,621, and I think we're receiving a lot more than that in services. And he wants to know what the service dollar amounts per county look like. And I don't know that he cares about any other county, as I've said before. We only care about Transylvania County. So is there a way to show Smoky investment in individual counties so that we can start bringing that forward at our meetings instead of just this quarterly report?
Let me try to answer that. And it's, yes, but I don't know
It's
if
the
it
short
would
answer,
be,
right?
satisfactory to the degree that he might desire. Because of the, we spent probably a couple of hours explaining about the money. If you recall, and there are state funds and there are block grant funds, and there are county dollars that all are pooled.
Right, and I understand all that. I mean, I think he's looking for a very simple answer, really and truly. And I think it would be a combination of what you've generated on the county level. I mean, he's, kind of asking about the service delivery, the types of service, and I think taking what you've already presented, that county level data, and then just kind of tying the dollars to it. And I mean, what you're talking about there is very analogous to how we fund our school systems. It's a combination of federal, state, and local dollars. So doing something, a single pager kind of thing is what I'm thinking about, that would just show.
Is it just, I'm assuming he would want to understand about the Medicaid, which is, magnitudes larger of what those funds are. Because if you're going to look at the services and the money in the county, there's probably 5 or 6 times as much Medicaid money that goes to support services. So it'd be the combination of Medicaid and state and local and block grant funding.
Yeah.
And what services that generates.
And I will say, actually, several of us, I talked with our finance director, senior director, Amanda and Donald, and we tried to talk through, and the state funding, because we allocate funds to the comprehensive providers who serve a region, and the movement towards a performance-based contracting, it becomes more challenging to just like per county. But we can go back to the drawing board and look at how we can try to carve out, and certainly our comprehensives have at some level some basic county budget, I would think, and we can investigate. It's just very challenging when it gets to how to show the comprehensive care allocation as an allocation for all of their services across several counties, and then break it down by county.
Yeah, so what it might look like in your area, a lot of that money gets pooled to serve uninsured people for the county in those walk-in centers. They basically have to be overstaffed, very similar to fire departments or any model system. So we're paying for capacity in those centers. So what we show is the amount of money that's sort of funding that capacity, and then the amount of people that access that center. And you'll see that a lot more people are walking in and accessing the services than that pot. So if you want to apply to just the county funds, this much money, and then this is the volume of people that the county's getting support for them to get those services, we can show that. But when we pool, and like Brian said, is we're pool, we have a couple centers that we pool across systems. So those walk-in dollars in our contract pay for walk-in centers across multiple counties in one cost center versus a separate cost center for each walk-in center in each county. Does that make sense?
It does. I mean, what's happening is I'm trying to defend you all, and I'm defending the fact that we're getting more than $99,000 in service.
Thank you.
You're on good ground with that one.
I know I am, but I cannot seem to get the other folks on my board to get beyond that $99,000, and they feel that this largesse is just so wonderful that we ought, that you ought to be able to do everything.
Ira wants to say something here.
Well, I was going to say, I've been in meetings with your providers. If you have like either your comprehensive or your other providers, they should very quickly be able to tell you or provide a very skinny report on how many people they served in each county. I've actually seen this. Y'all have seen them. So if they, and honestly, I think we've had this conversation before in Haywood, and I think just simply the types of services and the numbers of people served will go a long way.
Yeah.
And say that these are the uninsured, these are the non-Medicaid. I mean, the Medicaid shows part of the picture, but what they're really, I think, interested, that will go a long way in helping this discussion if you just simply get that number from your providers and put it up and tag it as part of your report.
And that's in the dashboard reports we've developed.
Right.
The one thing we did, I think the one thing that we're thinking about is there a way to, from those comprehensives, to say, in this county, how much do you spend?
And I know we've had this discussion in Jackson County too, how much do we get for $123,000 a year? That hasn't changed in, I don't know how many years.
20
20, okay. Not longer. Good. And Billy Kennedy from Watauga County has that same conversation with his board members, and he has to justify it to them as well. So, anything you can do to better enable us to get people who may not necessarily want to understand, to get them to understand as much as they're capable of, would be a big help.
And honestly, your public health boards may be a really good place to start too, in addition to dealing with us, to really look at doing some presentations to public health, because they're the department most impacted by what you all are providing. So to build that relationship and generate that education in your public health boards would be very helpful.
In our community health assessment process, which happens every 3 years, you find your top 3 priorities for your community. Mental health was our #1. And I do think that is part of what is keeping the conversation alive in Transylvania County.
Okay. Thank you, Elaine. Anybody else? All right, then we're moving down to the meat of this meeting. Hearing from Brian Ingram about the gap analysis and needs assessment, the budgeting process, and the community and capital reinvestment plan. That's a minute each, Brian.
I can do that.
No. Actually, the rest of us have done a pretty good job of keeping it short, so.
There's information in your packets about the state budget, as we know it, basically, as of the end of last week, and, the Senate's working on their version of things. I would say that probably the most detailed and helpful document would be this one. And so there's about $90 million in play with this. That would go against the reductions, the $263 million reduction that occurred as part of last year's budget process, the $110 million reduction statewide this year, and 152 or 153 for next year. And that goes great to, it's a great combination of agenda items, because the money that represents the Medicaid savings as part of our fund balance is what we use for our community reinvestment plan. So, if the General Assembly continues to reduce single stream funding and we are required to backfill that with fund balance, you will see less and less development in all of your counties. It's a very, very simple formula. We've talked about that in great detail, both with the board and I know with the community reinvestment plan that we explained to you. So this is, this part of the budget's, very, very important from a service delivery perspective, from a public policy perspective, and there could certainly be legal challenges around the General Assembly's ability to direct the use of Medicaid funds in our budget, which is certainly not what CMS has in mind when they do these kinds of things, and whether or not push would come to shove on that, I guess we would say. So that's what I can tell you about the budget, and I know all of you folks get a lot of information from your association. There's also the $30 million, and it's very confusing for folks. Everybody seems to be picking $30 million as the amount they want to work with, but the governor had a very big announcement about a lot of mental health and substance use and IDD developments that they're going to fund, and that was tied very closely to the governor's task force. I'm sure you've seen a lot of information about that, and we have that, right? That's in your packet. And I am delighted to turn over the rest of this to these two very capable gentlemen here, Jesse Smathers and Donald Bruce, who will give you an update. Well, no, I'm sorry, we're gonna do the gaps analysis first, you're gonna do the reinvestment plan first.
Yes.
All right, so let me rewind a little bit. Every year, just as you have your county-based health assessments, you know, we are required, contractually required to assess the needs that exist across our catchment area and to apply some understanding of how much resource exists against those needs. And as a managed care plan, as a health plan, you know, there's a very good reason for us to do that. And there's certain requirements around that format. You know, it's a helpful document, and we could spend a lot of time on it or a little time, however much you want. It's very extensive. Takes a lot to put it together, and it's just something that builds, you know, year after year. I think it probably gets better every year we do it because we understand more. I'm sure they'll tell you about the very extensive survey process that we have where we get input from counties by the multiples of hundreds. And so Jesse, take it away
Yeah.
before I steal any more of your time.
And I need to do it quick, is what I've gathered.
Yeah.
That's a little hard for me to speak quickly. You already started touching on this. The gaps analysis is really like, it's the first part of our planning for the whole network. So we're really creating like a macro level treatment plan for our network with regard to the gaps analysis. We take a look at what we have, consider all the things we may need. We create a plan, which is called the network development plan, and then we try to implement that. And as soon as we implement that plan, we turn around and start another gaps analysis. So it's a never-ending cycle. This year, the gaps analysis for the first time was outlined in a template from the Department of Health and Human Services. In past years, they've given us very broad instructions, and they've received very different responses from all the MCOs. They've received large documents from some MCOs, and as few as 2 or 3 pages from others, saying that they've assessed their needs and know what they are. So the goal of DHHS this year was to create a document that was useful, that could be used to compare the gaps throughout the state. And the template was pretty good in many places. Some of the major changes included the way we're supposed to do our calculations on our maps. Last year and in previous years, we've just looked at the number of people actually served through Medicaid dollars or state-funded dollars. This year, we were expected to consider every Medicaid enrollee in our catchment area throughout a time period. So that means people that would move in and out of Medicaid are captured in our numbers this year. And throughout the course of the year, we had 214,000 approximately folks funded through Medicaid and about 16,000 folks funded through state dollars. And here's a snapshot of the number of people we serve throughout our catchment area, which we're really touching a lot of people. We're touching probably what you'd expect when you consider our entire catchment area. There's about 1.1 million people. Our total Medicaid eligibles are around 170 when it's just full term, and then we're serving about 1/4 of those. And then this snapshot shows what we have in our network. We have a pretty large network for our 23 counties, a total of 3,001 credentialed practitioners. Now that number includes everyone that works for our comprehensives, hospitals, and other things like that. We have 374 total agencies, and then of course the 11 state-funded facilities. The gaps analysis puts some very standard guidelines around what is a gap. We looked at distance with regard to individuals to services. For urban areas, the guidance was 30 miles or 30 minutes. And for rural areas, it was 45 miles or 45 minutes in travel time from services. And we're supposed to have a choice of 2 providers for each person that's in our network within these guidelines. I'm going to just look at outpatient services. Now, the gaps analysis document that we've created is about 240 pages, and we will be posting it to our website after we've communicated it to all the players that we should before we post it. We've already communicated it to our board of directors, to the Provider Advisory Council. We're communicating it to y'all, and we'll be sharing it with our CFAC committee on June 10th, and then the document will be posted so that folks can access all the information there. But with regard to outpatient services, the expected standard from DHHS was to have 100%. Every Medicaid eligible should have the choice of 2 providers within the 30 minutes or 30 miles or 45 and 45. We scored 95.28% for Medicaid. We were a little higher for state-funded services. And here's an example of the map that was generated to demonstrate this. It's a little difficult to see on this, but there's an entire array of maps for each services, but each red dot represents a provider. Thank you. Each red dot represents a provider. The outline shows our catchment area, and then the 45-minute distance is in blue, and you can capture some of the travel distances. So you can see we have a lot of coverage in our network, but we still don't meet the 100% expectation. So to address that, we were expected to outline strategies, and just for outpatient services, we're going to target some licensed individual practitioners that are willing to provide certain services in different areas. And then, of course, with integrated care, we're looking at co-locating behavioral health services and primary care facilities and other things along those lines. This gaps analysis included a community needs assessment that was tied to surveying everyone in our network that was interested in participating in the survey. Last year, we had about 300 recipients or respondents to this survey. We quadrupled that number, taking it up to 1,263. And each year we hope to do better with that. We had 315 family members taking the survey. And the fact that we just did it electronic probably limits some of our numbers. And in the future, we'll be expanding that to use mail and other means. The themes from the survey were the identification of specific service gaps. And one thing that we always hear about in our catchment area is transportation issues, because it's such a challenge in rural areas. And then services in rural areas, limited office hours. We do have offices and licensed practitioners available, but sometimes I just work 2 days a week, so that limits the options for folks. It's not required in the gaps analysis that we address, well, it's kind of odd that nothing in the gaps analysis really requires us to address certain issues with IDD services, intellectual and developmental disability services, beyond just the service category. And from feedback that we received based on past gaps analysis, it was determined we should find some better way to survey folks with intellectual and developmental disabilities. Well, surveys for folks with IDDs already occurring with the National Core Indicators, so we incorporated this into our gaps analysis as a first step in making sure that the voices of people with IDD are heard. And the National Core Indicators is a set of survey questions where people actually sit down with individuals with intellectual disabilities and interview them to get answers to a set of questions. And for our catchment area, this is just offered to people with innovation services. We have 1,647 people in our catchment area that receive innovation services, and this National Core Indicator survey talked with 74 of those, and it looked at 7 different measures that we included in our gaps analysis. The questions in the National Core Indicators survey are tied to different things that are important for people with intellectual disabilities. The one that we were looking at in this presentation is community inclusion, because that's what we are really striving for the most with regard to IDD. It's to assure people that are included in their community. And this is an example of the responses that were given to by the 74 people. The response can be either yes, no, I don't know, or not clear. And looking at some of these numbers, folks that were questioned out of the 74, the majority appear to be getting some type of inclusion in the community, which is a positive. We tried putting all the responses on the graph, but it was too hard to read. And that is all I have, unless there's any questions.
Jesse, that statistic about access within a certain distance or time frame, is that from that consumer, that patient's residence, or from that county?
It's from the residents. It's tied to the residents. So any person in our catchment area that's living in a rural setting should either be within 45 miles of a service provider or a 45-minute drive. One of the two, which to me that's odd when you're thinking about rural settings. But because you can be 10 miles from somebody and it's still 45 minutes. But
You'll see on some of the maps, there, we have some individuals where that little yellow dot is actually located in a national park. And we're like, well, what do we do with those people sitting in there, there's no commercial, therapists we can get in there. It's people live in some rural areas where, there's going to be some people that have to choose to live a little further.
I'm surprised those percentages are that high.
I was going to say that very thing, Steve, that amazes me, that it's 98% or more.
for outpatient, yeah, it kind of surprised us that it was that high too. But there's a lot of availability within our comprehensives, within the hospitals and those kind of things. Because you have to remember, we're counting 3,001 licensed practitioners too.
On that, Jesse, I know just from some of our county meetings, for that day, so that would be like the just basic outpatient services. So there's a walk-in center. I need help, I can come to that center. And I know one of the things we've heard, and you mentioned on here, it'd be interesting to see if you know what some of the providers are doing about this issue is, especially in some of the more rural communities, looking at Nancy Mitchell, thinking of Cherokee Park. Recruitment and retention seems to be a really big issue. We may, they have the walk-in center, but sometimes people are transitioning. Do you all have any ideas about what folks are doing, or will we see more of that in the network development?
You'll see more of that in the network development.
Okay.
Yeah.
So we'll make sure because that is something that seems to be of concern.
I appreciate the concise nature of this, but it would be great to see, if possible, because I read your last year's report cover to cover. In something like this, where were we last year compared to this year? Have our Medicaid numbers gone up substantially?
Well, you said therein lays the challenge, because they gave us very different guidelines this year compared to last year.
But next year we can do this.
We're supposed to get more consistent guidelines this coming year so that we can really start comparing things. I think that our Medicaid eligible number has stayed about the same, may have gone up a little bit, just based on census data and those kind of things. The number that we have in this gaps analysis is inflated to that 214 because we are including everyone that steps in and out of Medicaid. Because a lot of people will come in for 2 or 3 months and then come out.
The other way to get at that, we have all kinds of performance requirements that we report on, and there's a penetration both for Medicaid and state funds report, I'm talking about now, and Christina. We could show you that, and it trends it over, I think, 12 months.
Well, it's just interesting in a county situation, to be able to look at the providers, have we lost providers through the catchment area? Have we maintained stability in the catchment area? Just to get our heads around what the bigger issues are for service for the individuals.
Well, and in the full document, you'll be able to do that.
Okay.
I'm just giving you a snapshot
Sure,
here.
no, and I appreciate it.
And you'll have that kind of detail on each service that's outlined in the document. And you'll have also a map for each service, which gives you a visual as an idea.
Okay.
And One of the things, once it's completed, I definitely will send everyone a link to it, so if you're interested. And then because of its length, it's very, I don't want to print a gazillion, but I would certainly commit to helping to print like one per county, if you want one. But I can definitely send you the link, and maybe with the network development plan will be out, then we can look at it.
So one key piece when you're looking at the document that you just want to have in mind is a office-based service. When you look at it, our standard is how far that person has to travel to that office for service. Well, we have a great number of our services are community-based services, which means that the provider goes to them. The person isn't coming to the office. So in those instances, we're applying the same standard. How far is the provider driving to provide services to that individual? However, we know we have specific arrangements with our providers that really drive a lot more than 30 minutes. So those providers, those individuals in those areas are getting the services. So it's not a lack of service. It's just that we're requiring, like mobile crisis is a good example. You see on the map, we contract with 3 providers to cover all 23 of our counties. Their base office site may be in Buncombe, but they have people deployed all over the counties in home-based offices and everything else for rapid deployment. You won't see any of that on the maps because the time and distance is taken from the office location. So you just got to kind of know some of those nuances around the community-based delivery system. So you'll see it in the narrative, but the map isn't intuitive, if that makes sense.
We might have some stuff we could give you tonight, Paige. Just steal it out of a subcommittee of our board.
Okay, I'll take
Get
it.
a lot of print stuff that's about that, so
Okay,
just
that's
remind
great.
us when we get done.
Sure.
Next, any other? Who's next?
No.
No, roll, you gotta go, roll it.
You let me go first, so I can go away.
Thanks, Jesse.
Thanks, Jeff.
Yeah, this is a very good segue. Again, remember what I said about the budget. The money that we're hoping will be put back into our budget for single stream funding, and how this relates to the network development plan, because we just took things we already understood that we had needs for, and those are obviously the kinds of things that we're reinvesting in.
Is that document clear enough, Brian, that we can take points out of it
Oh,
to
yeah.
send emails to our legislators? Okay.
Yeah.
Here.
I actually will email it out, are you talking about the budget information?
I'm talking about the single stream funding.
Yeah, I
said
can
saw
send
something
it out
about
at the
the
county
House.
commission meeting, so I'll just go ahead and send it out to everyone before I get.
Give us the 3 or 4 points that we need to hit our legislators with, please, so we can make that happen.
I will send those.
Okay.
I think Brian did a great segue there. One of the things that we had to really look at this year is that in years past, we've always did network development projects. We've always worked to reinvest our funds back into the community. We didn't really do a great job of showing people where and how we were doing that. Which, the emphasis for creating this document is really to get out and tell people what are we doing and how are we doing it in the community, so people see how we're reinvesting those cost savings that we've had in our system back into the communities. So what I'm going to go through tonight is a list of the projects that we have going on across our catchment area where we've identified our community reinvestment projects, how much money we've set aside for the initiation of those projects. Again, this isn't an exhaustive list, it's because we're always re-examining where we may need additional projects or we're able to reinvest some money. We're going to hit all the ones that are currently on our plan for development. And I'll talk a little bit about the ones that are already flying, moving fast, and one of them and the others are in the process that that we'll be able to launch if we don't get a huge funding cut in this next budget cycle. So when I presented to everyone else, I did a quick, what is community investment, where do the funds go for, but I'm assuming everybody here already knows that information, that our reinvestment or our fund balance is basically cost savings for Medicaid state funds. If we saved any money, it's in our fund balance, it allows us to reinvest it in the community. So that being said, I'm going to go through a couple projects. This is one of them here. has been going underway for the last year and a half, really 2 years when you really talk about the initial plannings of it. But we're working to develop a facility-based crisis center in Caldwell County. And you guys heard about that. We had a groundbreaking, some lovely people you see there with the shovels and hard hats. We're out there during that groundbreaking. Talking to Brian here a few moments ago, they said the facility's walls are up. They just put the roof on it this week. It's moving really quick, so we're expecting fall of 2016. That'll be a 12-bed facility-based crisis located in Caldwell County. The other piece of this project you'll see there is creating a medical clearance drop-off site in McDowell County, so officers in McDowell County don't have to go all the way to Caldwell County to see if somebody can get a bed there. They can stop at the McDowell office and get medical clearance. If they're medically cleared in McDowell, they know there's a bed available in Caldwell. They can drive them to Caldwell, drop them off, no wasted officer time. So those are some models that we're really trying to perfect and utilize going forward on how we can save community times, officers' times on taking people to centers and movement across our continuum. For some reason my PowerPoint is freaking, So that facility is going to be operated by RHA, which is our comprehensive care center in Caldwell County. If you guys have questions on any of these projects, then just stop me and I'll answer them, but I know I got short time.
Just as a reminder, we presented the community reinvestment plan at our last County Commissioner Advisory Board meeting, and this is a document that if I've been to your Board of Commissioners meeting that we talked about, and I will talk about at your meeting if I haven't been there yet.
Yeah. So we've had a project out, if you, some of you guys remember the state removed personal care funding from group homes 2 years ago in the budget, and they actually provided some replacement funding to the MCOs to keep those group homes going last year and to support that. There wasn't any funding in this current fiscal year to continue to maintain that, so we identified some funds out of our fund balance to continue to support those group homes to stay operational until we could, create a better funding mechanism to support those homes. So those funds are going there to really maintain those homes. We've also did a rate increase for our ICF MRs, looking at the types of individuals they were serving, what we need to grow in our system. We're paying a lot of costs right now to our state-operated facilities, and we really need to bring our community-based ICFs up to a standard to help serve some of those difficult people better.
Donald, with that increase, is that fairly comparable to other regions in the state, or are we having to?
Yeah, a lot of MCOs in this last cycle agreed to do that in unison to support those ICFs. So I remember, Brian, how many MCOs were doing that. I know us and Alliance and Trillium.
5%?
Did the 5%?
Rate increase, yeah, everyone did.
Yeah.
Remind me what ICF is?
Intermediate care facility. Yeah. It's the next step down for that state-operated IDD facilities. We also, you guys hopefully have heard a lot about this. We've been working on the C3 at 356, 24/7, 365 crisis center in Buncombe County. We could probably spend, an hour just talking about all the cool things that we're doing over there. Great facility, we got that off the ground. The ribbon cutting ceremony there, it's all coming into place. The last piece of that is moving our adult facility-based crisis center, which is down the street at Neil Dobbins, to the new facility. This is the building that Smoky was in previously. Remember that? Before we moved over here in order to create this facility. After that adult facility moves up, we will be working on the current facility-based crisis space, and we will be revamping that into a child facility-based crisis as soon as they move out. That will be one of the first child facility-based crisis centers in the state that will serve western North Carolina. So we're really excited about that and what that's going to do to try to keep children and youth out of inpatient hospitalizations that don't really need to be there. We're also, you're probably seeing the theme here, of really trying to strengthen our crisis system. because, we know we have a lot of issues, working, trying to keep people out of EDs that are getting stuck there. So you see here, we're also working with our facility-based crisis center in Haywood County, the Balsam Center. It's currently a 12-bed center, but we're expanding that facility to become a 16-bed, so that'll give us 4 additional beds at that center. We're also increasing staffing there and requirements in order for it to be an IBC drop-off. What that means is the Sheriff's Department doesn't have to get medical clearance at Haywood Hospital. Once we get up and running, they can go directly to the Balsam Center. They get medical clearance there, and hopefully we can divert people away from the ED directly into the center. So you see here in both of these projects we're adding roughly, once we add into this one, around 32 additional facility-based crisis beds across the region. This is a brand new venture that we're starting. We've identified that we still need some additional facility-based crisis in our northern region, the far north. So we're looking to develop a facility up there. We've initially targeted the current facility that's up in Wilkes County as being the proposed site. This is a picture of the current site where we have our walk-in center in Wilkes. And we're looking right now to see if we can build off of that site and create another 24/7 access point where we can create a lot more cost efficiencies in the system. And that's really what we're looking at now, is because we're seeing that if they're 2 separate facilities, they cost us a lot more money to run than if we try to merge them in 2 and create some cost efficiencies and staffing efficiencies on staffing. Next one, you hear a lot about this. We're doing a lot of stuff around integrated care in our network. We got a couple of things that we're doing. We've implemented some software. CMT is the name of that software, care management technology. Thank you, Christina. So we got a group of 15 providers right now that we have pilot projects with. They're using this software on integrating primary healthcare services into behavioral health type settings. So they have access to the software. They can see the healthcare data of the individuals that they serve through that data. We have a project with our comprehensive care centers. All you guys have one in your counties. So in this project, they are taking BMI, blood pressure checks on everyone before they see their doctor. It's hard to believe that providers on the behavioral health side wasn't really checking that in the past. I think when we all go to our healthcare doctors, we always step on the scale. They always check our blood pressure, right? It's just routine. But we're really trying to bring our providers more into that environment. So now all of our comprehensive care centers do this as part of their project. They have nurses, they have staff that are checking blood pressure, doing BMI checks, and are logging it in to the CMT portal so we can track that within there and identify whether there's any issues that need to be coordinated with primary care. We also have some, using some funds to coordinate with MAHAC, training our network on all of these critical issues that we need to address across our network to really bring our behavioral health providers into the healthcare world. I'm talking fast, I know, so slow them down if you need anything. ADATCs, you guys probably saw in the legislation, in the last budget cycle, they talked about moving those dollars through the MCOs, giving the MCOs a little bit more control of how that happens. There's still a lot of talk on what that is and how it's going to work, but we had some foresight to say, well, our community isn't ready to serve some of those individuals outside of ADATC. They're very complex people with healthcare concerns, substance abuse problems, and our community-based system, would really struggle to serve those individuals well. So we've started investing some money, and right now we're targeting really on that residential type of treatment model. So looking at sober living homes, looking at halfway house, three-quarter house environments where we can try to support people in the community as they're in their treatment. So we have at least 3 different providers we're talking to now to try to really develop some of those services across the catchment area. Technology-enabled care. I I could talk on this one for an hour, at least.
Okay, I'll get it for you.
Okay, so this Friday, you guys probably seen some of these. This Friday, we have a conference that we've been planning. It's called Carolina Health Tech Lives. Has everybody heard of it? Who hasn't heard of it? So I'd come down there and
You all have gotten an email on it.
if anybody I thought heard of it, it'd be you. We've been blasting this conference out everywhere, all over North Carolina, South Carolina, Georgia. It's been on the radio. You see, we got lots of ads on iHeartRadio. If you guys listen to the radio, all of their stations that they did it for us. LinkedIn, social media. It's been all over the place promoting it. What this conference is we wanted to help sponsor a conference to basically help our behavioral health and our substance abuse providers get more into the 21st century of treating people, what technology is out there to help people become more independent, what's available out there in order to assist them. So we brought in 35 vendors from all over the country that use technology on how to help support people in the community. So if we had more time, I'd show you a great video of an instance where a provider sets up a home using technology and sensors and talking devices on how an IED consumer can live independently in their own apartment and not have any issues just getting prompts and stuff from the home, as opposed to living in a group home with a bunch of other people. So really cool stuff. Pill boxes that remind people when it's time to take certain pills, instead of them just saying, oh, I have 4 white pills, I think I take one in the morning. They take the wrong pills, so pill dispensers will actually prompt and help people take the right medication at the right time. There's a couple that are technologies around eye movements and assisting people through eye movements and all kinds of cool technology we're bringing in. There's a watch that helps detect whether someone's getting ready to have a seizure, so they know to contact somebody. Kind of cool. There's all kinds of applications out there now around helping people with depression, anxiety, all kinds of cool stuff. So we brought in a bunch of vendors. We currently have about 600 people registered for the conference, which is really awesome. Most conferences in the state, when we look, we're probably about half of that size, so we're really excited about the number. We have some incredible speakers that are going to be at the conference, and I know I'm sticking on this one a little longer. But Dr. Gabor Mate, he's flying in all the way from Vancouver, British Columbia for the conference. He's a national speaker, one of the 4 known speakers around substance abuse and connecting the mind and the body in the treatment process of really helping somebody in the recovery. So really visionary type speaker, along with Lynn Siegel in the afternoon. She works in Virginia at an organization that serves individuals with IED, and she's basically moved every one of the individuals she works with to independent living. They all live completely independent in their own apartments, and they have severe and profound IED. So she's really exciting as well. She's gonna talk a little bit about how they did that and the commitment they made for that. And technology is a big part of that. And Luis Perez is kind of closing out the day. Awesome speaker in himself, works a lot in EC, Exceptional Children's Program, so we've been encouraging school systems and stuff to hear him speak. He speaks for Apple and does projects with Apple, creating apps, as well as doing public speakings on how to support children with exceptional needs. So, all of that to say is you're available, if anybody that's available, come on out.
But we're full, right? We can't take any more people.
We are, but I'm willing to make exceptions for any one of you guys.
Okay.
Send me your name and your email, I will get you in.
Just mention
Promise.
secret word, Donald.
That's right. We will get you in. So, if you got people in your organization, your school systems, your health departments, your DSSs, you would like them to go and just, here we're going to have the whole expo center, nothing but this technology really to support people. Let us know, we'll get them in, we'll get them registered the day of the event, and I think it's going to be pretty cool. So, any questions about that?
And you folks did, this information did go out to a lot of people. I sent it to this group, but I mean, it's gone to school systems, health departments,
Paige didn't get it.
others, but please, there's time, that'd be great.
No, so yeah,
Yeah, you said-
we've tried to blast everyone we could find and everything to try to make sure it got out there. Because we really have to start changing the culture of mental health and the substance abuse, disabilities, or what they are, and how you treat them and how you work with them. We're way behind the times. In healthcare, there's a new process coming out all the time, to treat people, and we're still just dealing with talk therapy. There's a lot more out there to support people than just talk therapy. This is an initiative that we did, and we moved past that, and you guys seen that. We invested $100,000 in purchasing naloxone. I'm familiar with all that is, but your EMTs in each of your counties definitely know what it is. This is an opioid antagonist that basically blocks the receptor. So if someone has overdosed on opioids and you use this medication on, you can actually reverse the effects of the overdose and save their life. So it's an instant life-saving drug. So a lot of the EMTs were carrying it, some police officers were carrying it. But we're in the middle of a huge opioid epidemic in western North Carolina, and we were seeing that across the state, and the people we were talking to said the supplies of this wasn't out there. We identified this nasal spray as a product that we wanted to purchase. Previous to that, all the EMTs and everybody in the communities were using needle injection to do the reversal, and you imagine a lot of family members, or if you come across somebody that is opioid, pulling out the needle and doing an injection is just something that a lot of people wouldn't do. But so we thought, well, this is a better way to really get it out to the masses. So we purchased the nasal spray as soon as it was approved by the FDA just this past year. It was approved, so we were one of the first ones to bring it to western North Carolina, and we began distributing that. We had our release on March 22nd. And already today, we've been using NC harm reduction as a distributor across our whole 23 counties. They've identified so far 14 reversals or saved lives due to the medication that we've put on the streets so far. So that's 14 people that are alive today because we were able to get that medication out. So whenever I think of that, it kind of gives me chills because, those people would have died if that wasn't available.
What agencies was this distributed to?
I could go through, if you go to the North Carolina Harm Reduction Coalition website, they list every agency by county that they currently work with to give the medication to. So a lot of your law enforcements are on there, EMTs on there.
So Smoky Mountain did not itself distribute?
No, we're working with
Okay.
NC Harm Reduction on the distribution. We looked at doing it ourselves, but why reinvent the wheel? These guys already have a huge distribution network across our region, and we're actually getting it into the people's hands that really make a difference. So we brought them in, we partnered with them, and we've made that kind of commitment to partner with people that are already doing some of the work as opposed to recreating things. So it's been a great partnership.
So do you know if it's available through our Sheriff's Department, Emergency Management?
EMS in Jackson, and I will say our.
EMS has it?
Yeah. I know that one of our staff who works with the coalition in Jackson is working with the Sheriff's Department now that it's the nasal to determine if they want it. And I will say our Brian Schuking, who was here earlier, his staff and Brad Owen, we have two sets of staff that are working in the community. And they're also talking about this and putting people in touch with the folks who are distributing it as they come across the need. Brian's staff has worked very hard to do the initial Narcan distribution and do some of the CIT training and other things for the community and through our prevention providers as well.
I know you only have 43 days left, but is that something you could check on?
I'm looking right now to see if I can put it on the list.
Okay.
That's 42
I'll put
days.
it on my list.
So is that not available to individuals?
Yes, it is.
I thought it recently had become available, is it over the counter?
You're talking
Availability?
about
Do you-
there's some legislation, and other states have done the same kind of thing. originally it was only available as a result of a prescription. So they've worked out an arrangement whereby I think it's the state health department director, physician in that office writes essentially an open order for, and they, I don't know whether they've chosen particular pharmacies or how they're doing it, but it's as if there's an open prescription so that somebody can go, and I know CVS has done this in other states. You go to CVS, you don't need the prescription, you can buy it as if it's over the counter.
Right.
So that's how they've gotten around that. So North Carolina has that law now.
I know I did want to share this past year, I did a lot of research and spent a lot of time on the subject of the opioid issue in Western North Carolina, and actually spoke at the NACO conference in Charlotte last year, the National Association. And my partner was a commissioner from Ohio, where the problem is tremendously bad. And I looked at it from the beginning as I was framed it more as a law enforcement issue, but it really goes way beyond that. I met in Charlotte with the Drug Interdiction Task Force, and went to their office, and they described the black tar heroin distribution system in North Carolina, and it's so elaborate that it's set up on a business model similar to Domino's Pizza in the way that it's delivered, the low cost, and they had recordings of drug dealers from Mexico talking to individual customers in Charlotte about where they satisfied with the quality of the product and the delivery system and things like that. So it's and I think the wave is not here yet. I think there's still another leg up in the black tar heroin business in particular.
Yeah, and this last year,
There are 14 right there.
yeah, so if you look on that, you can look for your county. There's also another web page where you can look at everyone that's currently being distributed to in your county. But this right here is a page where it just shows reversals and the number of lives saved through it. If it says all IM, that means it was done through an injection. Anytime you see the term nasal Narcan, those are all of our distributions. We're the only ones currently sending out the nasal Narcan. So.
In the North Carolina Harm Reduction Coalition, the group that we have worked with, they also provide this to individuals and family members.
Correct. So a lot of them were targeting opioid clinics where people are getting Medicaid-assisted treatment. And they're trying to get it into those family members' hands or those individuals' hands that are providing it. You can get it in some pharmacies now, but they have to pay for it. So, there's some other pieces out there. This is getting into their hands free of charge. So, and I was going to say, to add to your point, the CDC in this last year has targeted Western North Carolina as the epicenter for the heroin epidemic for the whole United States. Little Western North Carolina, because of the cross traffic between Atlanta, South Carolina, Tennessee, they think that we're going to get hit harder than anybody else. So if you hear it's hard, bad in Ohio, the wave's still coming for us.
I think that Ohio was the nexus of that black tar heroin epidemic.
So can you fully utilize 15 more minutes?
Yes, of course. I'm going to move really fast now. Okay, we also did the heroin summit. There you go.
And that was absolutely outstanding. I attended that. I hope you're going to do a repeat of it. It's one of the best training days that I've spent in 10 years.
Great.
And the individual you talked about from the law enforcement from Charlotte was a key speaker to that. Please do that again and pull public health and other partners in. Absolutely wonderful. Thank you.
Definitely. We're trying to do all we can with that. So you see we have sponsor that and kind of get that moving. We also have an initiative out to expand our IED crisis services. We're seeing a huge issue right now with individuals with IED getting stuck in emergency departments for long periods of time because there's no really crisis diversion place for them. You saw all the work we've done on the facility-based crisis, and those centers just can't house some of those individuals. So we're really trying to work now to develop some other crisis diversion places for individuals with IDD, because clearly ED is not the best place for them to be. So you'll see some initiatives coming out in the next 6 months around that on opening up some additional crisis beds, mainly like crisis respite beds across the region. YB LifeSets, I'll just touch on this really quickly. This is a model we're rolling out to all your counties. All of your DSSs are hearing about it on different levels. Hopefully they're hearing well. We're actually rolling out a brand new child service DSS continuum to all of your counties with several new services tied to it, and really to make a stronger, more impactful difference within that population. One of the services we're rolling out, and this is just a really cool service, it's called YB LifeSets. It's a program that targets kids that are aging out of the foster care system. So right now when you look at the data around those kids have high prevalence rates for being involved with the legal system. So they're aging out, they're getting caught in the legal system, going to jail. There's a high prevalence rate of using drugs and getting caught in the drug system. They have a large prevalence rate around being in domestic violence situations, being abused, being in bad situations, just poor partner relationship issues. This is an investment that we made and a commitment that we made to all of your counties and all the kids across our 23 counties, is that we're bringing this to all 23 counties to say we don't want any kids aging out of the foster care system without getting this service. This service basically goes in as the kids get ready to age out. They teach them healthy relationship skills. They help them find places to live if that's what they need. They'll help them find a job if that's what they need. They'll help them get connected with education if they need. Whatever that child's need is, or I say child, young adults' needs are, this program will attach to it and meet it. Now, the complication to that is that those individuals not always might have a mental health issue or something like that tags to them this need. So we basically, really targeting this money is that we're just going to make sure every child aging out has access to the service to really make a difference and try to break the cycle that a lot of these kids are in. So, a really cool program. I'll try to give some information to Shelley that she can get out. But this is one of several new programs that we're rolling out to your DSSs over the next 6 months or so. A lot of your DSSs are already involved in the new planning.
I read an article in People magazine about Stephen Tyler and his foundation in supporting this. So.
Yeah, Stephen Tyler has committed $7 million of his own money to support this, and the staff members within Youth Villages, which is the agency that developed the model, have committed $7 million out of their own salaries to match that.
Wow.
So pretty huge investment. They already have this service statewide in Tennessee, and they have the lowest rates for a lot of these issues in any other state in the country. So we really just wanted to duplicate that as well. This next one here, we're calling it Child and Family Reunification Project, but it's basically as we roll out this new DSS continuum and get these services in the community. Before those services were in the community weren't available, a lot of kids got into residential services and got moved away from their families. So this money is basically to go back in, reassess those kids that are already away from their families, and make a determination, is there any way, now that we have these new services and supports available to them, to bring them back and to support them with their families with these new services and supports. You know, not in all cases we'll be able to do that, but we think that there's some kids that are sitting in residential now that we can support them in their local communities back with their families with the right services and supports around it. So that's kind of what that project's about. This is a great one, and Brian already said it. The Community Engagement Awareness Project, we've committed $1 million. You see the kiosk there on the far right-hand side. Right now we're committed to put one of those in every county. Could be in your DSS, could be in your health department, could be at the CVS. Wherever is the most appropriate place in your county to start the conversation.
How about the library?
It could be wherever we decide where it needs to go. It just needs to be in a place that has an internet connection, and it has to, an Ethernet type of internet connection, and it has to have someone that can at least help service it and maintain it. You know, you gotta put some paper in the printer drawer and some stuff like that. So that'll be rolling out. Brian's group will be working with each of the counties to determine the best place to put this. On this kiosk, you'll be able to screen for behavioral health issues, substance abuse problems, and if they decide that they want to access services, you can't see it, but there's actually a phone right in there. They pick up the phone and it immediately connects them to our call center. So our call center can connect that person to services. There's also, we're working on another model, this product here that will also be at the expo on Friday called Healthify. Awesome tool, which basically helps connect people to local community support systems. So some of you guys know about 211, where it talks about, okay, what's available in my community, heating assistance and all this. Very similar to this, but it goes even a step further than a 211, and basically directs people and links those people directly to those services and supports. So it's a great tool. Once it rolls out, we'll probably want to show it to your health departments and your DSSs, because this is something that, like, even us right now, we track all this on pads of paper and spreadsheets and all kinds of stuff. This product will actually be mapping that and maintaining that data for us for all 23 of our counties, which right now is fragmented all over the place. So really cool product.
On these kiosks, as far as determining placement, is the desire to have it in a place where there's someone, a staff person who might be available if someone did have an emergent issue, or?
Potentially. We need at least one staff that we can train to help support it in case people have questions or something like that.
So it's more of that kind of support?
Yeah, but not like crisis support or anything
Okay.
like that. I'm not going to talk much about this, but we've committed additional money for our Medicaid assisted treatment, opioid treatment, Suboxone centers. Right now we have very limited funding for state funds for people that need Medicaid assisted treatment. The numbers are huge right now, so we're committing another $1 million per year to try to expand that care to our system and make that available to people. Jail diversion, we've heard this one loud and clear when we were on our tour of a lot of counties. We need to try to keep people with mental health and substance issues out of jail. So we've set some money aside to try to create some additional jail diversion projects across our region. So we're currently and will be talking with different counties that have jails. Paige, we've already talked with you guys about that, so you guys are on our list. And talking about how we can make that work in our system. Peer-run recovery centers, I'll go through that one real quick. Cool concept, but basically these are centers we want to sort of try to grow across our area to where peers are running recovery centers where individuals can access recovery supports through the day, but don't necessarily have to be peer support. So this is really seeding volunteer-based recovery centers where people in recovery are supporting other people in recovery. I'm going to throw these two up here together, SOAR expansion and transition to community living. Want to say anything about that one?
Sure. This is a partnership with Pisgah Legal, which operates in some but not all of our 23 counties. They'll be working on kind of things that we call social determinants of health, helping us with some of our consumers who have significant barriers to permanent housing because of convictions or credit history or rental history. And permanent housing is one of the biggest issues that prevents people from moving forward with mental health and substance use recovery. So we are funding, I think, 2 attorney positions.
2 attorneys and 3 SOAR workers.
Okay. They'll be negotiating directly with landlords, providing some representation on ADA accommodations, and then on the SOAR side, they'll be helping us with applications for SSI and SSDI. That's what
Yep, so excited about that. We're almost done. Okay, and the last one, we just added this one on. This one isn't even in your book yet, but we added on. We just recently set aside $350,000 to begin a veterans initiative on trying to improve access and engagement for veterans in our system that are either unable or unwilling to access treatment through the VA system. And we're seeing that all over the place. So we're trying to create some models that we can create some better access to services for them. So, like I said at the beginning, there'll be other projects that come.
We hope.
We hope if the General Assembly allows us to continue our efforts. So,
I did hear from Jackson County, Macon County, and I think there was one other county who during County Assembly Day had the opportunity to advocate for mental health funding, to not cut our state funding, and to support the governor's recommendations. So I'll send all those talking points back out to everyone, and then I'll be talking about it at the county meetings.
any questions? I know I went through that really quick. Everyone else, it took me at least an hour to run through. So,
Can I just see that last slide one more time?
Yep.
To make notes since it went in our packet, please.
yeah.
We can print it off for you very easily.
Yeah.
Email. Couple of things. You kept me engaged, and that is very difficult for me to stay engaged. I suffer of adult attention deficit disorder, or at least I claim that, or I'm easily bored. But yes, that was very good information for all of us. Steve?
Brian, if let's say the House budget version goes through and you continue to take hits and you make all these investments, what's the ballpark of what your unrestricted fund balance will be down to?
Well, if you use a word like unrestricted, again, I'm going to give you a kind of a ballpark figure.
Money available for community reinvestment.
Yeah, probably 30 to 40 million.
I do have a question on one of the services you mentioned. Under the agreement that you made with Pisgah Legal, even though the specialist would be housed in Nashville and in that district, is that something that any of the different regions could, because of the type of work they're doing, could be handled by basically out of the county areas? Or are they just going to be restricting their clientele to their area?
They actually went back to their board and got permission from their board to expand it beyond their, they have 7 counties. So they did get permission to expand it beyond some of those counties. They'll also be, they have a significant network of pro bono attorneys throughout the region, so they'll be working with pro bono attorneys who can do some representation as well.
Because it seems that would be a very specialized, once they get into it and learn it, that's going to be a very specialized area. And it might be the kind of thing that referrals could be getting from all over our catchment area.
Yes.
So they would be willing to do that, it sounds like. Okay, thank you.
Yeah, we hope.
Really?
All right, any other questions? What you got?
Thank you. Thank you.
I'm threatening to go fast. Just saying.
You thought I could.
Great job. It must be part of your training. You got to work for something like that well. Do we have any other business? Good meeting, folks. Very good meeting. Lots of good information. You take back to your commissioners, agencies in your county. We'll meet again in August. Hopefully around my birthday, so we can have a party.
You have to stay late.
Yes, or start early. Is there a motion to adjourn?
So moved.
Second, Bill, Paige, yeah, all right. All those in favor? Let's go.
And will you make sure you sign the, sign in, please?
Sign in, make sure you sign in.
I think you'll be.
Brian, I'm gonna get that pass.
Good to see you.